Hi everyone, my name is Hussain Rao, and I'm a USMLE Step 1 and Step 2 tutor with MedSchoolCoach. So today we'll be doing a question of the week, and it will be a USMLE Step 1 question. So here's our question. We'll start by just reading through it, and then we'll give a pause for you guys to take a second to think through it, and then we'll go through each answer choice. So to start off here, we have a 68-year-old man with a past medical history of coronary artery disease, hypertension, and asthma who comes into the clinic due to intermittent episodes of substernal chest pain and shortness of breath. These episodes occur while he is walking upstairs and during his morning exercises. His morning exercises consist of stretching and high-intensity walking. He is concerned about this pain as it has impacted his ability to complete his morning workouts. His pulse is 92 per minute and blood pressure is 128/82. Physical exam is unremarkable and EKG shows no abnormalities. A drug that blocks which of the following receptors is most likely to prevent future episodes of chest pain in this patient? Okay, so I'll go ahead and give you guys a second here. You can pause the video and take a second to work through this answer on your own if you want. So welcome back. I hope you had a chance to think about it. And now let's get into the answer here and go through these different options we have. So first off, it says muscarinic receptors. So a drug that blocked muscarinic receptors would actually increase this patient's chest pain. As we see with this vignette, this patient is having chest pain with exertion, with his high intensity walking and during walking upstairs. So this is likely an anginal picture that we're looking at. And with exertion, the chest pain with angina gets significantly worse. And so with anti-muscarinic activity or muscarinic blockade, that would actually decrease parasympathetic activity and increase the heart rate, cardiac workload, and myocardial oxygen demand. All these things are kind of similar to the picture that we see during exertion and would worsen the chest pain through kind of the same pathophysiology. Now, alpha 2 adrenergic blockade. This would actually also worsen this patient's chest pain because if you remember back to our pharmacology, alpha 2 adrenergic receptors are a negative feedback receptor on our sympathetic nervous system. So if we block our negative feedback on sympathetic nervous system, then that will actually increase the sympathetic nervous system output. In the same vein as the first answer, it will increase the chest pain because it will increase this time sympathetic activity and cause an excess of catecholamines. But effectively, we'll have the same result with increased blood pressure, increased workload of the heart, and ultimately increased myocardial oxygen demand. So that, again, will not be the correct answer here. So aldosterone receptor blockade. So this is representative of drugs like spironolactone or eplerenone, and these work by decreasing sodium reabsorption and inhibiting hydrogen and potassium excretion in the collecting ducts of the kidneys. Now, these agents are commonly used to treat CHF, and they're actually proven to decrease mortality rates. And while they're useful in that perspective, they're not useful to help treat the symptomatic chest pain of stable angina. So this will be incorrect here. So D is beta 2 adrenergic receptors. So this is closer as now we're actually blocking a sympathetic receptor. However, if we remember correctly, beta 2 receptors are more prevalent on the lungs, and beta 1 receptors are more common on the heart. And a common mnemonic for this is that there's one heart and two lungs. So in this case, beta 2 is not as specific as beta 1, so that will be the correct answer here. So let's get into an explanation for this question and kind of break down what we really need to know about this and how to interpret these results for future questions. So the first important concept to keep in mind is that it's really important to understand stable versus unstable angina. So some characteristics of stable angina are signs and symptoms such as the fact that symptoms are often reproducible or predictable. The complaints often subside within minutes, within rest, or after administration of nitroglycerin. And there are common triggers such as mental or physical stress, sometimes even things such as exposure to the cold. However, the relief of pain on exertion is the most commonly represented clue that we see for step 1 questions, as we saw in this vignette. Now, unstable angina, symptoms are not typically reproducible or predictable, and symptoms, most importantly, occur at rest or with minimal exertion. And also, they're not relieved by resting and not relieved by nitroglycerin. So those are two big differentiating factors to keep in mind when you're comparing stable versus unstable angina. And we know for stable angina, beta 1 receptors are helpful to decrease chest pain by mitigating the workload of the heart and by decreasing the myocardial oxygen demand. So here that we have the pathway kind of laid out. Like I mentioned, beta 1 blockade will decrease the sympathetic activity on the heart, which will lead to decreased heart rate and decreased contractility. And that will lead to a decrease in blood pressure, ultimately decreasing myocardial oxygen demand. It's also important to keep in mind that the beta receptors are specific for different organs and there's different concentrations in different areas. And this is most commonly tested by by having questions based on the understanding that beta 1 receptors are more commonly on the heart and beta 2 are more commonly on the lungs. Again, the mnemonic that we use here is that there's one heart for beta 1 and two lungs for beta 2 receptors. So I hope you can keep all these things in mind moving to future questions and hope that was helpful.